It's just a matter of seeing what the end goal is. Because listen, you talk about wanting to quit and feeling like you're losing your mind. Yes.
All right. Hi, everyone. Hi, my name is Rodalyn Joseph. I am a physician assistant and the host for Pre-PA Shadowing. And tonight we have Jackie Edwards joining us for the Occupational Medicine session. Hi, Jackie.
Hello, Rodalyn. Thank you for having me. Hi, everybody.
Thank you. Okay, so Jackie has been a PA for over 9 years. She has so many credentials, and her resume is very long. She's an author, a mentor, and an ambassador for the NCCPA. She's written books for both aspiring PAs and new grad PAs, and she's also an ambassador for Medelita, and also does consulting. So we just want to thank you, Jackie.
I don't have a clone. I need a clone.
Thank you so much, but especially thank you for joining us tonight and all you've done and continue to do for the PA profession.
Well, thank you. I'm always looking forward to opportunities where I can help shed some light on some information. So I'm ready. How we do it?
Great. Okay, so Jackie, just want you to first start off by telling us a little bit about yourself. How did you get to the PA profession? How long have you been a PA? And telling us a little bit about your past specialties.
All right. Okay, so for everyone who's just tuning in, because I see that number going up, I see these, look at the views, but I am a PA. I've been a physician assistant for the past 9 years. I graduated from Marquette University in 2011. Before that, I was a registered nurse. So I went to nursing school right out of high school, got my associate's degree. Then I got my bachelor's. And I honestly thought I was going to be like a nurse anesthetist, even thought about med school. And I had never even heard about physician assistant as a career because, no one talks about it. And it wasn't until I was a nurse working in the emergency department that I learned about physician assistants. I still kind of had my heart set on being a nurse anesthetist, but then I shadowed, which is why shadowing is so important. And it was boring. They make a lot of money. It sounds nice on paper, but I went to shadow and I was like, oh, this is what y'all do? Somebody's about to die. So because I would fall asleep, I need to be busy. So I decided to apply to PA school instead of nurse practitioner school, because that's probably like the question I get asked the most. But I applied to one PA school. And at the time, this was still a paper application. Marquette was not on CASPA yet. So it was old school. It sounds old school, but 2008's not that far away. And I didn't have physics. I've never taken physics, and I've never taken organic chemistry because at the time, Marquette had it as recommended. So, I had a bachelor's already, and they said it's more like to weed out people. And I got in, so look at God. Anyhow, when I went to PA school, at the time I was married and I had 3 kids. My son was 7 at the time. He's 19 now. And my girls were 1. They're 13 now. Yeah.
Wow, I thought you were in your 20s.
Girl, listen. Well, I'm trying to age gracefully. The 20s, I remember my 20s. But yes, so then graduated in 2011. My very first job out of PA school was in neurosurgery. I was one of those people that went to PA school because I'm like, I know I'm going to want to work in the ER. It sounds super cool to do surgery. So I did neurosurgery. Being a mom, having a family at home, the hours just did not work for my life. And I didn't have the greatest supervising physician, which is why I left that job. And then I went to work in the emergency department, which I kind of feel was like my comfortable place because I did that in nursing and it was fun. the only fun thing that I mean, like you got to do a lot of procedures. Everything was unpredictable. You got to have what I would like to call fleeting relationships with your patients. Like, I see you and I hope I don't have to see you again, even though I may see you again. I did that for 3 years. And then I worked in urology for 2 years. I'm kind of like a wandering spirit. And then that was interesting. I also worked in urgent care, where it was just straight urgent care. And then for the past 3 years, I've worked in occupational medicine, and it has like this much urgent care.
Okay.
I think I got all of where that was. We went through my cycle of being a PA so far.
Okay, great. I'm going to give everyone a chance to ask questions in the end, but just so we don't forget, it seems like people are going to want to know, how are you able to balance like having kids at home and going to PA school, or even like nursing school, or just any like rigorous
program? Any school, going to work. Listen, I am a big advocate of utilizing your support system. And that's not ideal for everyone, but my girls had never been in daycare because if there was weekends where they would be at one of my friends' house on the weekend, their godmom would keep them every other weekend. My mom would keep them every other weekend because the school week was like a work week for me. So, and then at the time, their dad worked just on a week. He did weekend program. So during the week, he would handle them while I'm at school. And then I would come home and do superwoman stuff that we do all the time. But I had a set study schedule. So, and that took some adjustment because I had been out of school for like 2 years before. Like, it wasn't like full time being in school all day. That was not where I was coming from as I finished my bachelor's, because I went at associates for nursing, then bachelor's. And I did that. That was like 1 day a week. So that, I mean, you don't have to do too much of an adjustment there. So like that first semester PA school, I learned I needed to adjust a lot. So on the weekends when my girls were gone, I would go like 8 to 5 on Saturday to the library, not at home, because if I'm at home, I'm washing dishes, cooking, all that stuff. I just had to have a set time to study. During the week, I would go to school and be there. Maybe like I'll start at 6:30 to start doing some studying that I didn't get. And then when I would come home, I wouldn't stay up past 10 o'clock because I believe in sleep. If I didn't learn it in the day and I didn't get it in between, like I study every time I could study, like eating time, I'm studying. After school, I would stay only an hour after school to get anything that I could get done, and then go home, and then I can focus on them until they were going to bed. Listen, schedules matter, y'all. But as they get older, it's easier and different. I would say like by time the schedule changed a little bit when they were 4 when I graduated. My son was in school all day, so that was easier. But once they were 3, I'll try to find them any kind of program that they could be in, half a day, full day or something, so that they could have some structure as well. But
okay. Wow,
use your help.
Wow. Like, it was hard for me, and I didn't even have any kids. Like, so.
Yeah, I think it's just a matter of seeing what the end goal is. Because listen, you talk about wanting to quit and feeling like you're losing your mind. Yes, I can tell you, like, I don't think this is for me. Like, I think the first semester I had miserably failed the written portion of anatomy and physiology, like 54%. And I was like, oh, I don't think I know how to do this. Like, who put all these muscles in the arm? I need to know what moves what and what. That just required me to do an adjustment. But I definitely was like, I don't know if it's going to work after the first semester. But I mean, I graduated cum laude. I got it together, y'all. Put it back.
Perseverance, guys. Perseverance.
Adjust and adapt. It's always going to be an obstacle. Somebody's going to have something, and you just need to. The excuses are plenty, and I'm not saying the excuses are not valid. It's just so much easier to be like, well, this happened, so I had to stop, versus figuring it out. And I'm all for figuring it out.
Right. Yeah, that first semester is definitely a lot of adjusting and getting used to like the exams and everything. I didn't even do that well first semester too. It was a big wake up call. So
I call it, because when they say the fire hose, of information, that's exactly what it's like, because everybody that's in your class is smart. So it's not a matter of, oh, you're not smart. You are with the smartest of the smartest people. So that's not it. It's just a matter of your technique. So I'm not good at rote memorization. Like, I need to always be able to apply it to things. So people often ask, oh, did nursing school make PA school easier? And I was like, for the clinical part and where you were talking more about the diseases, yes. But for just memorizing random biochemistry equations in the Krebs cycle, no. Like,
exactly. Same here. Because I was actually an LPN before becoming a PA. I actually did that in high school. So I went to magnet school. So that's how I was able to become a PA. So I can relate to you as far as, like, you know, clinicals and actually the diseases, all that. Pharmacology was even not that bad. But the anatomy, physiology, that first semester.
I'm telling you, I was like, who put all those muscles in the arm? You didn't even, I'm like, extradigitorum, what are we doing? Lord.
Exactly. And microbiome too. Microbiome was a little, but we got through.
We got through. Yeah. Don't quiz me on it now. I'm like, well, let me look that up.
All right. So we're going to move on to just the occupational medicine side of things. Okay. We want to first know, what exactly is occupational medicine?
So occupational medicine is this field. We work on work injuries, and we try and keep people safe in the workplace. And we work a lot with employers and patients. So, and I work for a big company. They're nationwide. So Concentra, I'm pretty sure people have heard of them. Yeah. Yes. And I do mostly work injuries, employee health. And no one, I think when I was in PA school, I don't remember that being discussed as a possibility of an area to go and work in. So I feel like I had to go through some fire to get to this position, because for me right now, it's very sweet in my life, considering going from like the ER to this. So I do a lot of work injuries, pre-employment physicals. We do drug tests, pre-employment testing, occupational hazards. So we do a lot of baseline exposure tests. So if someone's getting hired at like a factory job that they are exposed to chemicals, we do respirator fit tests, pulmonary function tests, basically everything that gets you working healthy with well-working employees.
Okay. Yeah, it seems like occupational medicine is fairly new.
Mm-hmm.
It's just a field just only for like workman's comp, basically, right?
Well, I mean, and that's the thing. So when I was working in the emergency department, I would see people who would come for initial injuries, and working in occupational medicine now, I'm like, oh, I was doing everything wrong. Like, you know, our job in occupational medicine is to make sure you are at your functional goal to be able to perform your job duties, but that, you know, you're not missing any time off of work. So it's really weird, because when you think of like HIPAA type things, you're working with an employer who is also being informed of the status of this injury, just the injury. Right. And you have to like make sure you are not crossing any lines, because people's health status can be blurred with an injury. So we do a lot of like work comp, and I was like, dang, in the ER, I was taking people off of work for 3 days, and I didn't know how bad that was. If you're working in the ER, don't take your patient off of work for 3 days. That's not good.
I'm definitely guilty of that.
Like, oh yeah, you can't use your hand. You need to be off completely. Like, I get it. Yeah. But so I do a lot of work injuries, a lot of DOT exams, which are always interesting. I think DOT has interesting personalities and an interesting health. So when you're talking about doing a head to toe physical, I think in PA school, that was probably one of the most stressful things, that you had to be like, oh my gosh, I got to do this whole head to toe. And then like, I do that stuff all day. All day. That's all I'm doing. They're like, I don't get this kind of exam with my regular doctor. I'm like, I know, but I do it all day. And I'm done in like 5 minutes. I probably can get everything I need to do.
Can you tell them what DOT is for those that don't know?
So it's a Department of Transportation federal testing that is basically this physical, and they have a book this thick that changes all of the time as far as regulations and guidelines, but it's a federal exam that the truck drivers take. So here in Wisconsin, because it varies by state who actually takes these exams, because our school bus drivers take them, but I also did this in Illinois for a little while, and their school bus drivers did not do DOT exams. But they're very particular as far as what your blood pressure has to be, sleep study. If you need a sleep study, if you screen positive, everybody gets screened for sleep studies. They're taking into account your height, your weight, your body mass index, your past medical history. There's specific rules for diabetes. You can't drive if you have seizures. You used to cannot drive. So before 2018, you couldn't drive if you were on insulin. And now you can, but you just got to get this big old packet filled out. There's just so much paperwork, and it's DOT exams for me, because I do them all the time. I don't have to like really think as hard. And if a patient's getting mad at me, want to cuss me out because they didn't get their card because a different company did not require X, Y, and Z. I don't get fazed by that. I'm like, yep, these are the DOT guidelines, not Jackie guidelines. So this is what I need, and bring it to me and we can get your card going. So I do a lot of, today was like a lot of DOT exams. Okay. A lot of DOT exams.
So how often do you have to renew your DOT certification?
Ooh, DOT certification, listen. So first of all, that's the only recertification that I'm not really thinking too hard about, because it's every 10 years. I was like, oh, it's a long time. But of course, if you're doing any continuing education, you want to be up to date. Our company is really good at making sure people know what the most recent guidelines are. We have like a whole department that just focuses on DOT. So if you have any questions about certain medications like CBD, everybody's using CBD, but you can't drive if you're using CBD. And that could come up and be a big issue. People on narcotics, if you're on like a benzodiazepine, like lorazepam, Valium, you take those kind of medications, we don't certify you. You can't drive while you're on those. And what's interesting is I was wondering why is it such a stickler? Why are there so many rules? So it looks like in 1999, people could go to their regular doctor office and get a DOT exam. You didn't have to take a test and get a certification to do it. You get to become a certified medical examiner through the DOT. But in like 1999, I think it was like on Mother's Day, this driver who was like on Benadryl, dialysis, fell asleep, killed like a bunch of people in the bus that he was on. And then when he fell over the bridge, it was a hot mess. So now they have all these guidelines, and they have different task forces that tell you what needs to be done. So I like to say, these aren't my rules. These are DOT's rules whenever a patient tries to go off on me.
Right. Yeah. And I've seen that before. I do urgent care now, and I did urgent care like rotations back in the day. My urgent care, we don't see DOT. But when I was seeing DOT patients back in on rotations, like they would get mad. They would get mad because of their blood pressure, even though they're not, on their medications. They're not compliant.
And I think it takes a strong personality and just this level of certainty, because they will try and bully you into like, well, somebody else gave me this. And I get their frustration because this is connected to their livelihood. This is how they work. So there's things that they call discretionary things on DOT that as a clinician, I can decide, okay, you know what, I don't have to stick to the black and white of the book. Like there's some gray area that I can operate from. So if your blood pressure was so DOT wants your blood pressure to be less than 140 over 90. So say a patient comes in, their blood pressure's 142 over 90. Well, I can still pass them and then make sure that they have, it's not really follow-up. It's just a little letter I give them to send back to me. But there's certain things that DOT is non-negotiable on. So you need to be able to see 20/40 out of each eye, and then 40 together. So if you see 20/50 out of your right eye, DOT is not going to give you a card. And I get people who are like, well, nobody ever told me. And I'm like, yeah, you got to be able to see. And you need to be able to hear out of at least one ear. So you could be deaf in one ear and still get a DOT card. But if you're deaf in both ears or you don't you're not able to hear past a certain frequency, then you don't get a card. So those are the two like non-negotiable. DOT just disqualifies you.
Okay, and would if they fail the vision exam, like if they get contacts, would it then be like okay to get DOT certified? Or?
Yes, but they have to they have to go through the whole physical again. So that kind of irritates people. They're like, I just paid for this, especially when they're private pay. I get people who are like, well, I paid for this. So they kind of feel that since I paid, there should be a little bit more leniency. And it's like, no, it's the same. Like certain things are just going to be non-negotiable, like especially right now. So I think 2018 is when the sleep study screening became more stringent, and then it became more of a standard now to make sure everybody's being screened. So you would get these young people. If your body mass index is over 40, you automatically need a sleep study. And you get people like, well, I'm not snoring, or I am not, I don't need to be on the CPAP machine, and, to help them. They don't know. And I'm like, yeah, once I get this test, I can tell you for sure. So that right now, because that costs, we don't run, a sleep study company or anything like that. We refer you. So that's another out-of-pocket cost for people. And to get a home sleep study test up here in Wisconsin, I know it's like $400.
Okay, wow.
For the test. Now, if you're positive, it can cost the least, I think, is like $798 to get the CPAP machine. But yeah.
It's not covering it? Or?
A lot of people. So I like to say that truck drivers, unfortunately, are some of the unhealthiest people that we will see. They sit down for long periods of time, especially when they're doing long haul over road driving, and they're obese. A lot of them don't go to the doctor unless they see somebody for their DOT exam and they think that that's their regular doctor. And I have to tell people all the time, like, this does not count as your physical exam because there's no screening that's going on. But I get a lot of patients who find out that they're diabetic because DOT requires a urine to be checked. And in that urine, you're checking for protein, glucose, and
ketones.
Well, yeah, ketones. No, I don't think it's ketone. No, it's blood, protein. Oh, blood, protein, and sugar. My gosh, why did my brain? Yeah. So I don't care too much about, but the blood and the protein in the glucose, they definitely care about. So I get people who just find out that they're diagnosed with high blood pressure because they came for a pre-employment exam. So again, we do a lot of pre-employment exams. So FedEx is a DOT people, UPS, they send people for DOT. And right now, the season's high.
I'm sorry about
that. I don't think that's me.
I'm so sorry about
that. But we get a lot of people for pre-employment. And if you tell them, they find out now that they have high blood pressure or diabetes or they need a sleep study. A lot of people have been out of work right now. So they come in and like, how am I supposed to do this? I don't have insurance. I'm trying to get this job so I can get insurance or at least get the money to do X, Y, and Z. So I definitely feel for them. But it's one of those situations where they have tight rules that need to be followed.
Mm. Okay. So can you tell us or run through a day in the life of an occupational medicine PA? I know, the type of patients you see, but just kind of when you clock in to when you clock out, how many patients you would see, or the patient population as far as old versus young, anything like that?
Yes. It's all right. It was all right for me because I'm like, as long as it's not me, I'm like, I don't think anyone's connected here. So my day, so I work Monday through Friday, 8 to 5, no weekends, no holidays, which is very important to me because work-life balance matters, and I don't want to work nights or the weekend. I've done my share. It's not that I've never done it. I've done it. But I work at a clinic where I am the only provider. And I contact my supervising physician is at a clinic that's just like a mile or so down the road because we, for some reason, are located that close. But if I need to call him or call another doctor over him, I just contact them by phone. That doesn't happen often. Usually it's when I have a question about something. Now my schedule it starts blank. So that's how it starts. And I get new injuries and then I have follow-ups. So new injuries do not come on schedule. So I may like today I did not have any new injuries. And I only had one patient follow up on my schedule, but we do walk-ins. And so most of your DOTs are going to be walk-ins. We do have some that do schedule an appointment because they take about an hour to do, not for me to do my part of the exam, but for the drug test and everything, the hearing test that the medical assistant has to do, that takes their visit like an hour. And then we get the people who just walk in for urgent care, which is quite different right now because of COVID. So when I first get to work, I have one medical assistant and I have a radiology tech person or my x-ray person who also does medical assistant stuff, and then a front desk. That's our complete staff. I have one of the lower volume clinics, which is nice for me, but it's not sweet every day. Like some days are super busy and you're like, how do these people find this clinic? And then some days it is, I mean, I may see, me personally may only see 3 people in a day. That doesn't happen often right now because there's a lot of hiring that's going on. And I like to say that injuries come in groups. So like I would go through, everybody's cutting their fingers and their hands, and then you get everybody who's got an eye injury, work-related eye injury or back pain. So they kind of come in groups. So I usually go through my labs, and because I'm the only person that orders labs, and right now, the labs that come to me are all the COVID tests. So with COVID right now, we don't see any private pay or like the public for any COVID tests or COVID symptoms. Our company's doing a real good job about making sure we're not unnecessarily exposed to symptoms given, because if we're out, then that makes it people out for these factory jobs. And I work in like an industrial area. So I work in the suburbs and I would say my population is probably more middle-aged than anything. I do see people from everywhere, but I don't see any kids. There's a children's urgent care somewhere down the road. So I can see kids, but we're not really equipped to see kids. So that if it's a kid, I don't see them. But so I check my labs. I think my nursing background, because I was like a nursing assistant and a nurse. So I have this control thing where I like to do certain things. So I call all my positive and I call my negative people. I then kind of see what my schedule is. And I'm open for anything. I guess that's the best way to put it. So for example, today was physical day and I had a lot of DOT exams and a lot of pre-employment exams. It takes me maybe 10 to 15 minutes at most to see the patients. And most of the time it's because the computer's taking a long time. So if I didn't have any injury today, I'm gonna go to a day where I had an injury. So if I have an injury, I kind of like to see how my patients are spaced out. I see patients faster than other providers do. And I think some of that's just based off of my experience. I'm used to working for productivity and I just like to get people in and out. People like to get in and out. They don't want to be with me all day. I can see as many, if you walk in at 4:58 with an injury, I still have to see you. So that's the only thing that kind of sucks about my job. So this follow-up that I had today, he actually worked at Costco. He was, at the time that I saw him, because now this is probably week number 3 or 4, that I think it's 4. He basically cut his right hand and he cut it into like, it was in the, it was like in the palm, but it was cut into a V. So it was like a flap almost, but it was deep at the same time. So I should have taken a picture of it, but that day I was hot, so that didn't happen. He had like a real thin piece of skin, and then it was deep here. He cut it on some glass because a bottle broke. A tequila bottle, all bottles. I have faith in tequila. But that's what cut his hand. And it was bad. I had to put like 13 stitches in just to kind of tack it down. And it's in a weird space because if he flexes and extends his wrist, he was going to pull my stitches. So the restrictions I had for him was he can't he can't use his right hand. It needs to be covered at all times because I didn't want him to break any stitch because his job is a cashier. They have to lift things at Costco and grip things. And if he did anything wrong, he could bust the stitches out of here because I was trying to keep it tight. Well, the very first visit, his blood pressure was like 160 something over 112. It was super high. And he was like, oh yeah, I just found out that I'm diabetic. So anytime I get a hand injury, because hands are nasty, y'all. Hands touch everything, especially if you work in a grocery store. You got to think of everything you're touching that somebody else has touched is pretty gross. So most of the time, if I get a cut on a hand injury, I'm going to put them on prophylactic antibiotics. And the data out there varies, but I have not had good luck with people with hand injuries and trying not to put them on antibiotics, and then they come back. Also, because he's a diabetic.
Right.
And it's not controlled. I don't know what his blood sugar or anything was, but I put him on antibiotics. So normally my sutures come out good. And it's not that this didn't come out good. It's just that it was like leaking a little bit after I put him on antibiotics. So I put him on Augmentin, and then I just waited. So I usually see my wounds, my lacerations or cuts in the hands, see them 2 to 3 days after the initial injury, just to make sure that it's not looking like it's falling apart. There's not all kinds of pus on it or anything like that. So, and then I usually will take the stitches out of the hand about 10 days. Well, I see him, I get his stitches out, but there's areas leaking. So then I was like, maybe it was just because of a reaction to the sutures, because I've had people react to the sutures and he was finishing up his antibiotics anyway. And well, today not today. We got to go back. When the next time I had him come back, like a few days later, it just was like weeping. So I sent it off for a wound culture, which came back last Friday, and it grew out some like actinomyces, some antibiotic that I did not think it was going to be. Not antibiotic, some bacteria I didn't think it was going to be. And I did not have him on the correct antibiotic for that because it was not what I thought it was going to be. So I just put him on a new antibiotic today based off of the sensitivity of that. And I'm just hoping his hand looks nice. It's just, because I'm like a perfectionist, so I get mad when my stuff doesn't come out right. And I'm like, why is this looking like this? So I got it all cleaned, and I think he's just not cleaning it all the way because he's trying to baby it. And he had like this theory strip that was just there forever. So I took all that off, and we'll see what happens. But yeah. When I have like a new injury, I would say like my most common injuries are going to be lacerations and back pains and shoulders. Those are like my top 3 of what I see. But I've seen other stuff. I see some eye injuries. I know how to use a slit lamp, which makes me feel so confident because when I very first got out of PA school, the slit lamp was just so intimidating. And I'm like, where am I looking? What am I twisting? So a slit lamp is like this super cool. It's like, I think this almost like the thing you see at the eye doctor when you go and they put this thing up to your eye, but you can see at the back of the eye, you can dye the eye. So that's like, now I don't mind eye injuries. I used to hate eye injuries because I'm like, I don't know how to do this. But the job I had before was in Illinois, and we did occupational medicine, and they did a lot. Like at where I'm at right now, I refer people. I can do some things, but I refer a lot of people, a lot more than I did in my job before. So that's always practice, depending on what does the company, what does your supervisor want. But at my other job, I used to like drill. What is it called? So if somebody gets metal in their eye, rust rings, I'm sorry. If someone gets like metal in their eye and it stays there for too long, you develop what's called a rust ring. And I learned how to drill those out. Now, yes. I don't do them now, which I'm kind of glad because I always get like this cold sweat of nervousness because you gotta like, you're sitting here and the patient's eye is numb with the eye drop, and you're like, just don't close your eye, and your eyes open and their eyes open, and
they're nervous.
I would not. I'm just saying, me personally, I will pray if something happened like that where I need to see an eye. I can go to an eye doctor because I know how freaked out I was putting with that. It's a little drill, like it doesn't drill your finger. Like you can put it on your finger, it doesn't hurt, but like it's just eyeballs freak me out, y'all.
Yeah. Okay, thank you so much for that run through. So, so next we're gonna go into case studies. Everybody loves the case studies, and the way we do it is that you're basically we're first going to have a student come on the video with us, and you're going to walk through a case study, kind of similar to like the cases you've been telling us about, but it's more so just so they can learn more about like the assessments that you do, and so it's not necessarily just to get to a diagnosis. You can tell them what the diagnosis is, but walk them through.
I was thinking hard. I was like, how am I? If they're students, how are they going to know? Good. Yeah. So basically, I'm just walking you through what I'm thinking as I'm seeing somebody come with something.
Right. And what you would do, so, a patient comes in, if they have a laceration, you take a look at it, you assess it, what specific tests you would order and why you would order them, certain things that are specific to your specialty, like occupational medicine. So, yeah, and then you kind of ask them questions, why would I do this or why would I do that? So it's not it doesn't have anything to do with the actual diagnosis or treatment, but just so they can learn and learn about what you do as an occupational medicine PA.
All right.
Okay. So for this first one, we'll just have Jackie, go through one and explain it rather than student. Then the second one, we'll see if a student if we can get somebody to come on.
Well, okay. Well, I will go in more detail about my hand one because I guess I didn't really go into a whole bunch of detail. Because with occupational medicine,
okay, so it looks like Christina.
Okay,
we're going to get Christina on.
Hello,
Christina.
I don't know if my camera is going to work, but hi.
We can hear you though.
Okay.
All right. So, I'll go first with that one because there's things that I didn't talk about that are specific to occupational medicine that, you need to always make sure it happens. So I can't remember how old he is, but he's like, I think 50 something. And he is a newly diagnosed diabetic new injury. And they just tell me it's a new injury. That's how my staff tells me. And we find out that it is a cut. So we always want to get the story. So when I know it's a cut, I'm already having my room prepped by my medical assistant who knows that I want my size gloves and just the suture kit out, because not the suture kit, but the suture kit itself. And I grab my own sutures. I clean my own wounds. So I don't, after they're in the room and they get the history, I'm in the room by myself with them. I don't call them in because I go in the zone. But with him, it was important in the history to know what happened. And with occupational medicine, it's so important because any of these cases can be brought up for like litigation. If somebody decides that a work comp case may more likely be in the common case. Oh snap! We got a party.
We're able to get Karen on.
Another room, another person popped up.
Like Karen was able to come on.
But anyhow, so when he comes in, he has a lot. I'm asking him, tell me what happened. And he says that the customer put their bottle of tequila on the belt. The tequila fell over. He didn't know it was broken. So when he picked it up, his hand got cut, but he didn't even realize the hand got cut until he saw the blood was there. And then the blood was it was a lot of blood. So Costco is like literally down the street from our job. His supervisor brought him in. And I always ask, okay, which hand are you? Because that's when it's coming. If you cut your non-dominant hand, I'm always thinking ahead of what restrictions am I going to put in place. So when he cut his hand, it was glass. He didn't feel that I asked, do you feel like there's something in your hand still? Because I want to know, like, does it hurt? What does it feel like? He said he didn't have a lot of, but I think it was just a shock. And I asked him, okay, does he have any numbness or tingling? because it's important for me to know how deep this cut went, what all was damaged. And when I went to see him, his hand was all the way wrapped up. And I was concerned because your ulnar artery is in here, and this is where his cut was. But she had his whole hand wrapped up, so I didn't know if it was on the radial end. She said it was bleeding a lot. So, and I wanted to make sure it wasn't too deep, where I would have to send him to the ER, because I can do some things, but if it's too deep and it's an artery, I have nothing to tie it off with but the pressure. So he cut it with the glass. He didn't feel there was any glass in there. One thing that I wanted to do was x-ray his hand. And do you have any reason why? Do you want to know? Not know. I'm not good at asking the questions. Can you tell me why I would x-ray his hand? There we go.
Yeah, that's a good question.
There's a lot of bones in that area, so if there's glass caught in there, you might be able to see it on imaging.
Yeah, so not so much the bones, but definitely the glass you could see on imaging, depending on how thick it was, if it was a big enough chunk. And if I'm closing up his hand, I don't want to close up glass, because that's going to create problems and could make a worse infection. So he didn't have any glass in there. The other thing that I wanted to ask him was, when was his last tetanus vaccine? And I do that for everyone who has a cut. We have a record system here in Wisconsin where you can look up immunizations, but a lot of times people don't know. So if they don't know and I don't see it there, they get an immunization. So his tetanus was updated. He had not been to a doctor, I think, in like 10 years, he said, which is why he didn't know that his blood pressure was that high, and that he was diabetic. So once I saw that his blood pressure also was like through the roof. And the thing about injuries in occupational medicine, you can't just focus on the injury itself. Like, he can have this going on, but he could die from a heart attack. So I wanted to recheck his blood pressure, and his blood pressure was still as high. But I was able to do my next step. So after I get his history, my medical assistants go in and do all the history. It's really important that I verify the history, because sometimes my staff does not know how to either spell something, so they won't add it, or they don't know what the diagnosis is. So it's important for me to always review, so that I'm always thinking legally. Can somebody sue me?
Girl, me too.
And it would fall on me if I didn't check that. So it's important to clean wounds. Now, I don't know if you heard me earlier mention this particular guy. The wound is called, it was a flap. So part of it was thin, and then it was thick and deep inside of his hand. He missed his ulnar artery, but I could lift up the piece of skin meat, but I wanted to see, and what do you think I'm looking for when I'm looking in his hand after I lift up this skin?
Any visible blood vessels or nerves in the area?
Can't really see the nerves good, but tendons is something that I'm concerned about. Because if you get a tendon injury, I'm definitely sending you to the specialist, because I can't repair tendons in my clinic either. And then I let them decide. But even though he had pain, so he didn't have any visible tendon injury. It was just mainly just the skin and then the muscle underneath there. And I also wanted to check his strength. I wanted to check his hand grasp and his flexion and his extension of his wrist. Because even though he's bleeding out of his hand, I need to make sure he has these baseline functions. And it hurts. And I tell patients all the time, I get it. It hurts. I'm not gonna lie. I just need to test this, and then I numb them up. So before I numb my patients up, I like to, not before I numb them, before I clean them, I like to numb them up. And the reason being is, you will come into practices where the medical assistant or nurse or whoever is expected to clean the wound, but cleanliness of a wound is most important, because you're trying to prevent infections. And you can't clean a wound when somebody's saying, ouch, it hurts. You're just not going to be able to scrub and get off extra. I'm almost debriding it, I feel like, when I'm cleaning it, because you want to clean it real good. You're irrigating. I wanted to look and make sure I didn't see any visible pieces of glass in it before I cleaned it out. And then I have a sense of security in knowing that it was done correctly when I do it myself. You can definitely train your staff to do it. I do have my staff trained to do that. I just do it myself. It just works easier. And then we have different suture sizes for the hands. And because it's in a place that he can move, I use the 4-0. It's thicker, but then it's not too thin where it's going to break if he moves. Again, I put 13 stitches in, and I'm just thinking of things specific to the job. So suture care is one of the things that I have to go over with patients, because I get patients who will come in and they won't take the dressing off at all. So you have to reassure them that you're okay to clean it. So I show every patient, after I put the stitches in, we count so they know how many are in there in case they come on a day that I'm not there, or they go somewhere else and someone takes them out. And then I show them how to clean. So I have them wash their wounds with soap and water, just regular soap and water. That's what they have at home. Make sure that they pat it dry. And then if it's a work injury, I give them the antibiotic ointment, and then dressings, because I don't want them to give me any excuse as to why it's not, why it's not taken care of. So what do you think some of the warning signs are that I give patients to look out for at home? Because instructions are very important with work injuries, I guess in any injury, but things to look out for.
If there are any signs of infection or loss of motor or sensory function, so if it gets
swollen. You can be tomorrow, yes, all of that. So that's my big thing. I'm big at verbalizing it, and then I write it all down. So there's a part that goes to the employer, and that's written on the employer's note. And I always say, wash with soap, water, pat dry. Change the dressing at least once daily, and then as needed. And I usually have them keep it covered most of the time for 2 days. And then outside of that 2 days, I tell them, leave it open to air so that it's not getting all moist and macerated, because bacteria likes moisture, and if you're diabetic and it's uncontrolled. I'm pretty sure that's what happened with him, because I just keep thinking this. But hand injuries are, you can get a nasty hand infection, and that's the hand that you use. So I put him on antibiotics. I actually put him on Augmentin, and it still looked infected. And then I ended up culturing it 2 weeks later, because it wasn't infected. It ended up changing it. Now with a work injury, I get off his history. So now his blood pressure's high. He's telling me he's an uncontrolled diabetic. I can't ignore those. So in my documentation, I write that I need to inform, he needs to follow up with his primary care doctor. And then if he has any chest pain, shortness of breath, he should go immediately to the emergency department. And his job does not, the system's set up where his job does not get off his past medical history. They only get history that is pertinent to the injury. Because I have had patients that have had other histories that you can't just, like if you have history of HIV, his company should not know that he has that. So I do write that he needs to follow up with his doctor. And then I make restrictions based on the injury. So for this particular injury, I need to know what job he does and what's his dominant hand. So he told me he's right-handed. He's a cashier. Well, Costco is like, they carry all this heavy stuff and they got to lift and move and all that. So he's going to be limited. And my concern is getting it infected. So he needs to keep it covered while he's at work. And then I restricted him on not to just use the right hand, because even if he grabs a little bit, he can like mess up my stitches, and then we'll have a different problem. I tell him to look out for fever, chills, drainage. And then I always outline the typical plan. So for my sutures, most of them 2 to 3 days get a wound check to make sure that it's not a bad infection, that the antibiotics are working, we're not having any issues. And then usually 10 days is when at 10 days from when the stitches were put in, I take the stitches out if they're able to come out. Sometimes I'm not able to take all of the stitches out. I don't have to give them anything for pain. Tylenol or ibuprofen, because a lot of times people want to know if they need to be on anything for pain. Tylenol or ibuprofen, he said he was completely fine doing that. Trying to think what else I'm missing. It's hard for me to ask questions.
No, you asked some good questions. You asked some good questions, and Christina did great.
I know. I told her you're hired, girl. You can come work with us right now. But I am thinking of, like, I had a patient. He had a back injury. He was like 20 something. Worked for like a construction company outside, and he didn't fall. He was just twisting and throwing something in the trash, so he twisted his back. But he had a history. His past medical history did include HIV, and he was very, very, very concerned about, like, his employer finding out that history. And I know for me in particular, my operations director called me just to make sure I'm like, I don't write any of that stuff on there. You just gotta it's important to make sure that the history the employer gets because of HIPAA is only the history that they need. And there's I can't think of a circumstance where they would need to know that a patient has HIV and they pulled a back muscle doing something that's physical.
Right.
It's so important to know where the patient works, what type of job are they doing. If you have questions, I always call the employers after an injury to let them know that I saw the patient. This is what I think is going on. This is how long it'll take. I see patients maybe on average 3 times after an injury because they do these metrics, and I can get them back to full duty. But staying in communication with them, because your relationship in occupational medicine is not just the relationship with the patient. You actually have this duty and service to the employer because they're working with you because they're like, okay, you know what? You know occupational medicine. So we know that you're going to be able to get the patient back to work. You're going to make sure that they're not unnecessarily taken off of work. That's important. And missed time is really bad. That you're not going to give restrictions that aren't pertinent, because if you have a right hand cut, there's no reason that you need to be completely off of work if you can still use your left hand. So the employer's job, and I explain to every patient, because they're like, oh, am I going to have to go to work? And I'm like, well, the only time you're not going to be at work is if the job cannot accommodate your restrictions. And there's some jobs that are like that. And I personally I've only taken people off like that day if you have a head injury. Head injuries, I don't know if you have a concussion, so I'll take you off of work that day. But otherwise, I don't take anybody off of work.
I have a question. Speaking of head injuries, when do you refer them to the ER or transfer? When would you transfer patients?
For head injuries or in general? So there's not many times that I refer people to the ER. So a head injury with a neurological deficit, like they can't speak, they were out, or if they were older and on a blood thinner, I'm going to have to send you, because I can't order a CAT scan. And right. It's just, I can't do that. I've sent somebody to the ER once. I had a guy who worked for a beer company, and he was like in his 60s, but he had like his stomach looked kind of pregnant. He got hit in the stomach with a barrel of beer, and he had like this bruise, and he was on his abdominal exam. He was just really like jumpy off the table, and his blood pressure was super high, and he's never had high blood pressure before. So my concern was there a tear, because these beer kegs are heavy, working for this beer company. And I needed him to have like a stat CT or something going on in the stomach so that we can make sure he wasn't bleeding internally. And the funny thing about that story is, being a nurse, I know I go back and check my vitals. So because I just had bad experiences where people don't really know how to check blood pressure. And we call the fire department, and the fire department's like, oh, his blood pressure is 130 something over something. And I was like, let me check while I'm in here with you, because I know his blood pressure didn't drop down from, like 180 something over 119 or whatever it was. So I was like, let me check. And it was high. It was super high. It was not 130 something. So that person lied. I always check your vitals too and cover your butt. But I sent him because I thought he needed some imaging. I haven't sent anybody to no, I didn't send it. I send people to specialists a lot. Like I'm thinking of a guy that I had who he fell off a ladder, maybe 10 foot high. And he said like it hurt to walk. Like he said he landed on his feet and then kind of fell over. And I remember this from PA school is that if anybody is the story we were told, if somebody's running from the police and they jump over a fence and they land on both of their heels, it can be, if it's a high fence, they can get these calcaneal fractures, and it's bad because the fractures in your feet and the heel can show other injuries. So you can have like fractures in the spine. So I get this guy, and I was just really riding on the fence of if I needed to send him to the ER, because this happened at like 9 a.m. I'm not seeing him until like 2, because now he's at the point where he's like, I can't walk. So one ankle and foot was swollen, and his other leg just hurt. And he ended up just seeing the orthopedic specialist, because I was able to get x-rays of like his spine. He didn't have back pain. I was just concerned about that. So there's things I run through my head. And sometimes that's when I call my supervising doctor to see if I'm like overthinking, or if I'm underthinking. But I don't have too many work injuries unless they fall. If they fall and it's traumatic, because you get some companies who want to save money and they won't call 911. I had one guy who fell, and I think he had to like fracture quite a few ribs because he fell from like 20 feet, and his job brought him in, but he could barely sit up. Like I could barely like touch because he had such pain. And I sent him to the ER. So
I have a question. Like working in occupational medicine, how you said a comment earlier, like some doctors will have the patients not work for X amount of time to heal from their injury. And so how do you work with, like, you always want to hope that your patient is going to be a good patient and doesn't do anything to worsen their injury, right?
Right.
But then with the hand one, especially with his job being so active, how do you, like, what are some things that you would be able to do as a provider to keep him like on track, if you get what I'm trying to ask?
I totally get what you're saying. So for the example, the hand guy is easy because we have plenty of injuries that come from this company, and that's why communication with the employer is very important, and telling them what they are able to do and what they're not able to do. Now the problem lies in when they're at home, and you kind of get a gauge after being around people for a while who's going to listen and who's going to do something totally opposite. For example, I had an injury. He was a back injury. He's out of shape. He's doing a physical job, and he's using poor body mechanics. But you also get like this inkling. He didn't want to work anyhow. So he was not going to work, and that becomes problematic, especially when I give you restrictions and you just take it on yourself not to go to work. These cases can be closed by the work comp carrier for non-compliance. They're gonna be like, well, you're choosing to do what you want to do. Go ahead and do what you're going to do. We're not going to cover it anymore because we're laying out the guidelines. So communication in occupational medicine is real key. I try to over communicate. I let the patients know that I'm calling your job, but then I also tell them what to do, because you get a lot of younger people who are working with restrictions because they have a back injury. A common one. People are just not in shape. They need stronger cores, y'all. But you get some people who they want the restrictions for work, but they go home and they work out. So I'm like, you can't do deadlifts. I've seen it enough, so I have to tell people you can't go do deadlifts and bench press. It kind of works with me and lets me know where they are. And she'll give me a subjective thing. She'll tell me, as well as some objective things, but she'll tell me like, hey, this patient's not really trying, because you get some people who just don't want to go back. But my motivated people, they make it happen. I don't have any issue. But I think to answer your question, contacting their job and letting them know that this is what I saw. And I'm one of these people. If I know it's an injury, I like to walk around because I want to see how you're walking when I'm not looking. I have had people walk without any issue, and then they go to x-ray, or they see me looking at them and they're limping and dragging a leg. And I'm like, I just saw you walk in. And I document all of that. You gotta be consistent.
Thank you.
Okay. Thank you so much, Jackie, for that. And thank you, Christina. You did amazing. Like Jackie said, I think you're already ready to be a PA.
You're hired, girl.
So thank you, Christina. I'm going to take you off of the chat, okay? I mean, off of the video session.
Bye.
Thank you so much.
Thank you, Christina. Bye.
So, guys, it's 8 o'clock. Time just flew. So, unfortunately, we won't have time for a second case study. And I do see questions that you guys have. I'm going to stay longer to answer questions in the chat. Well, I'll get off the session, but I'll be here answering questions in the chat. And as far as Jackie, thank you so much, Jackie, for taking this time to answer the questions, to give us a run through about your occupation and occupational medicine and the life of a PA. And we just, being that the students don't have time to ask you more questions, how can they reach you? And is it okay for them to reach out to you with questions?
Yes, I am actually putting it in the chat right now. They can email me questions, because then I can go in and answer more. Because the issue with Instagram is that I don't always check that other one, so I don't want people to think I'm ignoring them.
Okay, great. Yeah, and I put her Instagram so you guys can follow her. It's @_I am Jackie. She has a lot of inspirational and fun stuff on her Instagram. So, and then her email.
I am I'm super laid back and chill. If y'all have not figured that out, I'm a type A- B+ personality. I have a gregarious type personality. I know my stuff, but I'm just real chill and real. So if you're looking for a super formal, well put together, I have a little bit of sophisticated ratchet, I call it. I'm educated, but I'll get you together.
Thank you so much, Jackie. Thank you.
Tell Candace I never take any. Listen, my job, I take nothing home. I come home, there's nothing. I don't have my charting. I'm not after hours doing any charting. I've done enough of that. So I come home, nothing. I'm not after work charting. I'm not bringing charts home. My chart is done when I get the patient out the room.
Me too. I try not to also. As a new grad, it was hard. And whenever I start new professions, it's a little hard. But once I get used to things, no, because they don't pay you for that.
Listen, and I get mad anytime I have to leave after 5. I'm like, I'm on salary. Salary is decent right now for me, though. So I've got the years in to make worth my deal. Not a lot of paperwork, but yeah, tell them I'm gonna try and answer some of these in the chat.
Yeah, I mean, once we get off the session, you can stay. You should be able to still see the chat. I mean, okay. Or if whatever questions that weren't answered that you guys have, just feel free to email her or reach out to me as well.
Okay.
All righty.
Yes. Send me an email.
Thank you.
All right.
Alrighty, guys. So I'll send more information for next week's session. Just make sure to follow us on Instagram, Facebook, and we'll put out more information about the upcoming sessions. And I'll also be sure to answer questions as it relates to the quizzes, watching replays, and anything that you guys may have. So once again, thank you so much, Jackie. You did amazing. I learned so much about occupational medicine myself. So
listen, I wish someone had told me that we didn't have occupational medicine is really sweet. It's great for work-life balance, and I'm definitely all about work-life balance. Okay, we have a job to do and we have a life to live. And while medicine is a big chunk of my life, it's not everything. I told you I got all these kids. Y'all can't hear them because they're teenagers and they're on the phone, so they don't care right now. Oh, people ask a lot. I don't have a lot of mental illness issues in occupational medicine. Yeah, I don't deal with a lot of mental illness unless like it's in their past medical history. I'm thinking like DOT wise, that would be the only time I would have to address any mental health issues. And I definitely don't get opioid addictions. We have Narcan in case somebody gets dropped off. I have dealt with them in my past in the ER, but not in occupational medicine. They usually get dropped off in the ER. But yeah, all right, yeah, I'll try and answer some of these questions. But thank you so much for having me. See,
I loved you.
Now I know what to expect next time, and we can always do this again because I'll be better prepared.
Oh no, you did great. You were perfect.
Because I talk a lot, girl. I would be.
I love your energy. I love it too. You're so laid back and just easy to talk to.
Listen, that's how life has to be. I just think with medicine, and I think that's why my patients like me. Because I mean, most of my patients really like me, and it's because I'm a straight shooter, and we can talk about other things, and I'm going to make sure you're better and everything. So yes, but yeah, y'all send me an email, and I hope if you can add it back in there, so then they can. And I'll answer everybody's questions.